All right, good evening, everybody, and welcome. Hope everyone's staying safe with some of the inclement weather we're having, but want to thank everyone for joining our webinar tonight. My name is Darren Schumacher, and I'm the Director of Marketing and Business Development here at OSMS. Tonight, we have Dr. Gordon Roedel to talk with us about partial knee replacements. Just so you're all aware, we are recording this webinar, and the webinar recording will be made available on our website at osmsgb.com/webinars by early next week. If you have a question, please leave it in the Q&A box, and I will be asking Dr. Roedel your questions after the presentation. So now, before I turn it over to Dr. Roedel for his presentation tonight, I have a few facts about OSMS that I'd like to go over with you. And so we'll get into that with the presentation. And there we are. It's going to pop up any second. Here we go. So first of all, just wanted to let people know if we can advance the next slide, Dr. Roedel. There we go. So a little bit about OSMS. So we are a doctor-owned orthopedic, sports medicine, rheumatology, and pain management practice. We have 9 locations throughout northeastern Wisconsin, so you can see them on the map. And we do have a number of doctors. So we have 26 on the orthopedic side, 8 rheumatologists, and 3 pain management physicians. Really what that means for you is it means that you usually don't have to wait long for an appointment, that we can get you in quickly, especially if you are in pain. You want to see a physician quickly, and we can certainly do that. In the next slide, it talks a little bit about how we have a full range of services at each of our locations. So on-site X-ray, MRI, we do CT scan for extremities, bone density scans, as well as an EMG test. And then we also have on-site infusion therapy treatment for things like rheumatic diseases, among other things. We do have 2 orthopedic surgery centers in Neenah and in Green Bay. And then we have 3 walk-in injury clinics in our locations in Neenah, Green Bay, and Oshkosh, where you can walk in and actually see an orthopedic physician without an appointment. And it's charged as if you had a regular office visit. So there's no emergency or urgent upcharge. And lastly, while we don't employ physical or occupational therapists, we do have physical and occupational therapy at all the OSMS clinic locations, which is a nice convenience for our patients. We do know that we are not open 24/7 and on weekends. So what we do is we came up with a program called Ortho Access. It's free injury advice anytime, anywhere. It's all web-based, so you don't have to download an app to use it. You can start engaging with us on our website. But if you're not sure if you have a new injury or pain and you're not sure if you should be seen or if you should just rest and ice it, what you should do, you can talk with an orthopedic expert for free and again, get that advice on what you should do. So it's a nice added value for our patients to be able to get that advice and find out, do I need to go into your walk-in clinic tomorrow? Do I need to go see somebody right away? Do I rest and ice? What do I do? And so we wanted to talk a little bit about that service. And then the last thing before I do turn it over to Dr. Roedel is recently we extended our hours at our Green Bay and Neenah clinics. So Monday through Thursday, we are now open until 7 p.m. And those are for scheduled appointments, or that is also for our walk-in injury clinics. So for orthopedic or sports medicine care, you can get that until 7 p.m. Monday through Thursday nights. And now it is my pleasure to hand it over to Dr. Roedel to discuss partial knee replacements. So thank you, Dr. Roedel.
All right, thank you, Darren. And thank you to everyone for joining our discussion tonight. Hopefully we'll have some lively debate and conversation about partial knee replacements. As you may have noticed from our title slide, the subtitle for this talk is, Can the Part Be Greater Than the Whole? So before we get too far into partial knee replacements, just wanted to give a little bit of my background. I'm a Wisconsinite, born and bred, grew up in Loyal, Wisconsin, small town in the center of the state. I did my medical school training at UW-Madison, and then went on to do a 5-year orthopedic residency at the University of Nebraska. And before returning back to Wisconsin, I did do 1 additional year of training. I went out to West Virginia and did a year of focus training on adult hip and knee reconstruction. So learning multiple techniques for partial and total knee replacements while I was out there. So my current practice at OSMS really is full spectrum care for hip and knee arthritis. That ranges from diagnosis of arthritis, non-surgical management, including medications, bracing, and injections. And then on the surgical side of things, again, that full spectrum, including minimally invasive partial and total knee replacements, anterior total hip replacements, and then revision of failed or painful hip and knee replacements. And so tonight, of course, we're going to be focusing on those partial knee replacements. So just a brief outline of where we're going tonight. We're going to start by talking a little bit about the background with partial knee replacements. We'll spend some time talking about why someone may be a candidate for a partial knee replacement. We'll go through the surgical process and what you could expect from a recovery. And then we'll talk about the outcomes and how these partial knee replacements do, particularly in comparison to a full knee replacement. We'll spend a little bit of time looking at some of the future directions that are on the horizon for partial knee replacements, and then we'll summarize what we've talked about at the end. So just a bit of background on knee osteoarthritis. This is the wear and tear type of arthritis where we see that cartilage that coats the end of the bones tends to break down and wear out over time. The result can be pain, swelling, and stiffness within the joint. And what we know is that this is one of the most rapidly growing causes of disability in this country. And so within the knee, this is really a tale of three compartments. We're looking at that medial side of the knee, the medial compartment, the lateral compartment, and then the area under the kneecap that we call the patellofemoral or PFJ. So the reason that it's important to really think about those three areas of the knee has to do with where arthritis occurs. And this was a recent study that was published that actually broke down for patients where their arthritis occurs by percentage. And what we found somewhat surprising was that about 50% of patients really only have arthritis in one part of the knee, one compartment of the knee. And they broke that down further to say, which areas were involved. And so we see that for many patients, that medial side of the knee is the area where that arthritis is present and most severe. About a quarter of patients have isolated arthritis in that medial side of the knee. More rarely, we'll see lateral-sided or patellofemoral isolated arthritis. But it stands in contrast to the conventional thinking that arthritis is present throughout the knee joint. In many cases, it's just one or two areas. So I think it begs the question as we begin, why would anyone want a partial knee replacement? If you could have a full knee replacement, why would you only want part? Well, the answer is that a partial knee replacement translates to a faster recovery. Patients are able to get back up on their feet, get their movement and their range of motion back, and return to activities much faster than after a full knee replacement. This, as it's a smaller surgery, it also lends itself well to a minimally invasive approach. Smaller incisions that are muscle sparing that also facilitate that fast recovery. Because we're only replacing the worn out part of the joint, we're able to preserve healthy bone and cartilage. And as a result, patients have a knee that feels and behaves much more like their normal knee, their pre-arthritic knee. And lastly, we find that this is a safe surgery, has lower risk compared to a full knee replacement of infection, blood clots, heart attack, blood transfusion, readmission to a hospital, and even death. So with all of that information, the question you might be asking yourself is, should everyone be getting a partial knee replacement? And the answer is somewhat surprising. So this is data that was put together from the American Registry of Joint Replacements. And what we see is that in 2024, only 3.5% of the knee replacements in the United States were partial knee replacements. So, well, this is confusing. Why are there so few partial knee replacements if they do so well? We see within this registry data that only 25% of orthopedic surgeons do any partial knee replacements at all. And over 90% of the surgeons that do some amount of partial knee replacements do less than 15 per year. So really what this comes down to, it has to do with some historical information about these partial knee replacements, historical data on their outcomes, and a poor understanding as to who is an appropriate candidate, what are the involved risks, and will the knee replacement last? So I think this is a good point for us to transition into talking about who is a candidate for a partial knee replacement. And these are the classic indications, and you'll find these are very restrictive. These are the indications that were originally published back in the 1980s, but for many years have been considered really the Bible for who could get a partial knee replacement and do well. So you'll see that, of patients who present with knee arthritis and knee pain, only about 5% actually meet this criteria. And what these outlined is that there really could only be arthritis in one part of the knee. The ACL needed to remain intact and functional. This was only for older patients, people older than 60 years old, and it was not indicated for young patients. Really minimal deformity was tolerated, so the knee had to be within 5 degrees of neutral, and they had very strict weight restrictions for patients, no more than 180 pounds in this initial publication. They also did not recommend performing these in patients with inflammatory arthritis, things like rheumatoid arthritis, psoriatic arthritis, or ankylosing spondylitis were immediately excluded from this. And then patients who had a partial knee replacement could only perform low impact activity going forward. And then the last criteria listed there is that patients had to have good motion going into the surgery to expect a good outcome. So over the years, each of those areas had been investigated and studies were performed to determine, are these strict criteria that are in place really necessary? And what we found is that many of those criteria really did not translate in the data to actually be true. So breaking these down one by one, if we look at the presence of single compartment arthritis and pain, what we actually found is that patients who have mild arthritis in the area behind their kneecap or the lateral side of their knee still have very good outcomes with a partial knee replacement, as long as they don't have significant pain coming from those areas. We also found that the ACL is not necessarily a hard requirement to be intact. More so, we're looking at the wear pattern that's going to predict stability of the knee after the partial knee replacement. And so whether or not the ACL truly is intact, a partial knee replacement may still be possible. We've also since found that patients of all ages can safely have partial knee replacements, and we actually find that many young patients actually do better from a functional standpoint than their older counterparts. We've also expanded the boundaries for what sort of deformity can be corrected up to 15 degrees. And then when it comes to the weight criteria, that's really not part of the equation anymore. What really is more important is the patient's bone density to ensure that the implant's going to remain stable. Studies have found that patients with rheumatoid arthritis and other inflammatory arthritis can safely undergo partial knee replacement, and there's really no increased risk of failure among patients who are more active. So really the main criteria that still remains is that patients should have good range of motion going into the surgery to expect a good outcome. So these are our modern indications now summarized. And again, we see this as much less restrictive. 15 to 30% of patients may actually be eligible for a partial knee replacement. So now we're going to get into the details of the surgery a little bit more, talk about really what it is we're doing with the partial knee replacement and what to expect. So the basic principle of a partial knee replacement or any knee replacement is to resurface the worn out cartilage and bone with metal and plastic implants with the goal of restoring normal anatomy. And so you can see in the diagrams here, we've got images of a medial partial knee replacement, a lateral partial knee replacement, and a replacement of that patellofemoral joint. And in each of those cases, what we're doing is removing that small amount of cartilage that was worn out and replacing it with a metal cap along the femur, a metal plate on the tibia, and then a plastic insert that goes in between to allow smooth movement between those implants. In terms of how we get into the knee, as we mentioned, this really lends itself well to minimally invasive approaches. So, the traditional parapatellar approach that can be used to enter the knee is one option. Certainly that approach can be shortened or restricted in its length to allow us access to the knee. My preference is actually to use something called a subvastus approach. So it allows us to make an incision that travels under the muscle and allows us to lift the entire muscle and tendon over without cutting into those structures, so that we're able to expose that knee with minimal damage to the soft tissues around it. Once we're in the knee, we're then just making some very minimal resections. So removing somewhere between 4 to 7 millimeters of combined bone and cartilage thickness, as well as the meniscus on that side of the knee. And it's really just enough for us to replace it with the thickness of the implants that are going in. So again, the diagram on the right here shows us those implants, that curved metal cap that goes on the femur bone, that thin base plate for the tibia bone, and that plastic liner to go between them. And then the rest of the knee is left intact. I'll often examine the knee, make sure that the cartilage still looks good in those areas, but we leave the ACL, the PCL, the collateral ligaments, and the rest of the cartilage in place so that it's really a normal knee. Another piece of technology that is very helpful with this type of surgery is robotic assistance. So this allows me a very high degree of precision when I'm planning and performing the knee replacement to make sure that we're restoring normal anatomy. I can essentially map out the patient's anatomy. We get a digital 3D template of what the bone surfaces look like, and then we can stress the ligaments to make sure that the implants are put in the appropriate position with the appropriate size. And so really the big advantage in my mind is that it allows us that accuracy within 0.5 millimeter, while also allowing us to create that complete plan for the knee before any cuts have been made. So once the cuts have been executed and we've got the trial implants in place, we will confirm that everything feels appropriate, that it's sitting in the right spot, and it's exactly what we want. And then the final implants are fixed in place with the bone cement. So this is an acrylic. It takes about 15 minutes to set up, and by the time it's fully set, those implants are completely secure and ready for weight bearing. So the surgery itself takes about 60 minutes, and as we said, once patients wake up from anesthesia, they're ready to get up and start moving and putting weight on this. So after surgery, our patients wake up in the recovery area. We'll get some x-rays of their knee and use some medications to help keep them comfortable as they're waking up. Then they move to our extended stay area, and we make sure that food and drink are going down okay. Again, we're making sure that their pain is well controlled, and then we have them assessed with physical therapy to make sure that they're safe to discharge home on that same day. Really, our pain control after partial knee replacement is multimodal. So we rely on use of ice, anti-inflammatory medications, and Tylenol, and early mobilization to help take care of pain. We really try to limit narcotic pain medications at this time, and so our patients use this multimodal technique to try to get off those medications as quickly as possible. The dressing that we put on at the time of surgery remains in place until a patient comes back to see me in clinic, and so they don't need to do any dressing changes, and they're okay to shower right away over that dressing. And we encourage our patients to get up and start moving, and it's okay for them to leave the house even for short excursions in the few days after surgery. So the early part of the recovery is focused on allowing things to heal. Our patients are weight bearing on the same day of surgery. They're working on some exercises to help get those muscles back in action, and then just using a walker or a cane for some support and balance as they begin physical therapy. In the mid portion of the recovery, weeks 2 to 6, patients are starting to advance that activity, walking a little bit farther, building up their muscle strength, and weaning themselves off pain medications completely. We often get questions about when it's okay to drive after knee replacement. And for our left knee replacement patients, once they're off any opioid or narcotic pain medications, they're safe to drive. For patients who have a right knee replacement, it's that same rule plus the ability to walk without the walker. At that point, we feel that they have enough muscle control to safely get behind the wheel. And then the later phase of recovery is getting back to normal activity. So at the week 6 to 12, I'm encouraging my patients to work on walking longer, walking farther, and starting to incorporate other low impact activities. When we think about the long-term perspectives for partial knee replacements, we generally will examine x-rays 1 to 2 years after surgery and then continue to monitor on 5-year intervals. My advice for patients is that I want them to use this knee to stay mobile. I want them to stay strong, work on their balance, and the overall goal is to maintain that mobility and avoid having a fall or another injury. Another question that we often get after knee replacement or any joint replacement surgery is if antibiotics are required before dental procedures. And what we found is that for most patients, no antibiotics are required, and that it's safe to undergo those dental procedures once they're at least 3 months out from the surgery. So at this point, we'll translate into talking about some of the outcomes that we can expect with partial knee replacements, again, especially as it pertains or as it relates to a total knee replacement. So when we look at the early recovery after knee replacement, we see that patients with partial knee replacements report lower levels of pain, higher activity levels, and greater satisfaction with their knee replacement compared to their counterparts with full knee replacements. When we look at some of the historical data, again, this is some of the areas that have, I think, made surgeons a little bit nervous about expanding indications for partial knee replacements in the past. So some of that historical data would look at outcomes going out to 15 years. And when we talk about survivorship, we're talking about what is the likelihood or what are the percentage of individuals who still have their partial or total knee replacement at that time, who have not needed to have it revised or had it changed. And so at 15 years, about 75% of partial knee replacements are still in place compared to 90% of total knee replacements. And the top causes for this to occur typically were loosening of the implant, resulting in failure or progression of arthritis in the other parts of the knee. But again, that's more historical data. When we look again at that registry that I mentioned earlier, and we look at the long-term survivorship within that cohort here in the U.S., what we see is at data out to 12 years, we see about or just under a 1% difference between partial and total knee replacement. The partial knee replacements have about a 5% revision rate versus 4.2% for the total knee replacements. And so I would tell you that the techniques and the implant materials that we use now have improved. And so I think that the numbers that we're seeing here are much truer to what the survivorship actually looks like in the range of 90 to 95% when we get out to 12 to 15 years. I do think that this is a really important thing to consider. So those previous slides are looking at survivorship and risk of revision and sort of assuming all things are equal, but that's not really the case. If a revision surgery is needed, what we find is that the outcomes to take a partial knee replacement and convert it to a total knee replacement tend to have outcomes that are very similar to a primary total knee replacement. Whereas patients who need to go from a primary knee replacement to what's called a revision total knee replacement tend to have a little bit more difficult course and tend to have poorer outcomes, higher rates of complication. So in the event that a revision is needed, I think patients who do have a partial knee replacement tend to do very well with that subsequent surgery. So thinking about some of the things that are on the horizon here, some of the future directions for partial knee replacement. There has been definitely an emergence of robotic navigation and artificial intelligence technology in this area. Lots of tools that we can use to help us be more precise with where those implants are placed and how the knee is balanced. We're also looking at some different ways that we can fix those implants to bone. So we've talked about the implants being cemented or glued into place. There more recently has been some look into using press fit implants, or implants that have a cementless fixation to the bone, and the bone actually adheres to the implant itself. And so that may offer some opportunities for better fixation and lower rates of loosening. And then as these indications have expanded, we're seeing more of these cases, we're doing more of these cases, and that greater level of experience can translate to a lower revision rate. So I think the takeaway from this is that there's opportunities for much better fixation and balance, which should translate to less loosening and arthritis progression and continued improvement in that survivorship that we see on those previous slides. So in summary, I think it's important to know really about 50% of knee arthritis is isolated to just one part of the knee. The other parts of the knee still remain intact and in good shape. Partial knee replacement is a less invasive surgery with a faster recovery, and patients feel better afterwards. The indications for partial knee replacements are expanding, and while there is still a higher rate of revision, that gap is closing. So with that, I'm happy to open up to some questions and have some more discussion about partial knee replacements.
Thank you, Dr. Roedel. Appreciate that conversation and that presentation. That was really interesting. So for anyone that does have questions, please use the Q&A area to submit your questions. I'll go through as many as possible and address as many as time allots. So I'm just going to do a quick look here to see if we have any questions that have popped up so far. So we do have a question here. So is recovery, I know you talked a little bit about it, but maybe expand just a little bit. Is recovery faster for a partial knee replacement compared to a total knee replacement?
So yes, that recovery is a little bit faster. We mentioned that, and I'll go into a little bit more detail on that. So after the partial knee replacement, again, patients typically have less pain and swelling compared to their counterparts with a full knee replacement. And that moves them along that recovery timeline faster. So I often see that my partial knee replacements have a comparable range of motion at 2 weeks to what I see in my full knee replacement patients at 6 weeks. That means that once they're getting their motion back faster, they're able to start advancing to strengthening and other parts of the recovery. And so I typically tell patients to expect, a reasonable timeline for return to work after a partial knee replacement would be somewhere between 4 to 8 weeks after the surgery. Obviously, that depends a lot on what the individual does for work, what their demands are, and sort of their individual recovery. But it's not unusual for patients to be getting back to those activities much faster.
Excellent. Thank you, Dr. Roedel. We do have a question here. So what is the process to know if you are a candidate for partial knee replacement? So how do you determine that is what I'm thinking that question is.
Absolutely. So if I've got a new patient coming into my office with knee pain, whether they're specifically thinking about partial knee replacement or not, we evaluate things in the same way. I'm going to do a physical examination. We're going to really do a very comprehensive look at the knee and make sure that we're understanding where their pain is located, where it's coming from, what sort of maneuvers make the pain worse or better. We're going to get a detailed history so that we understand, does the pain really seem like it's localized to one spot? Is it diffuse around the knee? And then we'll obtain some imaging. And sometimes that involves x-rays. And sometimes x-rays give us a very clear and comprehensive picture of what's going on. Sometimes the picture is a little bit more nuanced, and we may need some additional imaging, such as an MRI, to allow us to see if there's any cartilage damage in other parts of the knee.
All right, great. Thank you, Dr. Roedel. We do have another one. Another question here from Michael asked to speak to knee scoping to address some wear and tear issues rather than partial or full knee replacements. So maybe talk a
Yeah,
little bit about when that's appropriate.
that's a great question, and one that we get very often. So a knee scope, what I tell my patients is a knee scope is addition by subtraction. So when we talk about arthritis, if you imagine that slide that we had early on, the arthritic knee has cartilage that is wearing out, is breaking down, and so sometimes there can be some areas of that cartilage surface that previously were smooth and glassy. Now they're rough and disrupted. There might be some small flaps or areas of irritation. And so if we put a scope into the knee, a small camera through a small incision, and then, shaver tool or other utensils that go through another small incision, what we can do is we can try to smooth out those edges, the areas where things are rough. But really, all we can do is remove from the knee. We're taking cartilage out. We're trying to make it so that's less mechanically irritated, but we're not replacing the cartilage that was lost in that area. And so this is an area that has been an intense area of study. Are knee scopes appropriate? Are they helpful? And there was a recent publication within this last year that showed that when we look at whether a knee scope can, push knee replacement off, can delay the need for knee replacement, what we found is that it actually does not delay the timing for knee replacement at all. And we actually find that there is some increased risk or increased concern for an infection if someone's had a recent knee scope before undergoing a knee replacement. So in the cases in which we will consider it, in which it can be helpful and safe, is for an individual who's having significant mechanical symptoms. If they have a cartilage flap that is getting caught and causing the knee to lock up. If that individual's not yet a candidate or not yet ready to undergo a full knee replacement, we may do that surgery to try to help alleviate those mechanical symptoms, but it's not going to fix the underlying issue. It's probably not going to actually put off knee replacement.
All right, thank you for that. We do have another question about how many partial knee replacements have you done, and how often do you do them? When was your first one completed?
Yeah, so I did partial knee replacements as part of my training in Nebraska and West Virginia. In practice, I believe my first partial knee replacement I did I want to say the first one was in April of 2024. And so since that time, I've done about 30 partial knee replacements. And to this point, everyone's doing well. Everyone still has their partial knee replacement. Again, this, in my opinion, seems to be one of my most satisfied cohorts of patients in terms of their ability to get back to normal activity and feel that they have a knee that they can trust.
All right, great. Another question here, this one from Martha. When do you anticipate the anchoring will be osteo-integrated and not cement retained?
That is a great question. That is one that I am continuously looking to see if we have updates. There is one implant in the U.S. that is a cementless fixation, or is that osteo-integrated fixation. We'll get just a little bit into the weeds here. I don't want to get too far into the weeds on this, but that type of knee replacement, the particular model, is one that is called a mobile bearing knee replacement, meaning that plastic insert that goes between the two metal pieces, rather than being fixed to the tibial plate, is sort of free to move and slide in there. And so the idea with that type of knee replacement is that it's hopefully feels a little bit more natural, allows for more natural movement. But one of the concerns or consequences that can occur with that mobile bearing is that sometimes if a patient has a fall or twist the knee, that sometimes that mobile bearing can actually dislocate from the area. So not an implant that I typically use in my practice out of concern for that potential risk or that complication. And so, but we've been really kind of pushing the industry to come out with a press fit or a cementless model of that fixed bearing implant that we use. I think it's something that will probably be available within the next 2 to 3 years. Would be my estimation.
Right, great. We have another question here. This one from Larry, and I believe this has to do with total knee replacement, not partials, but I know you can comment on this. He asked if you can comment on the Jiffy method of knee replacement.
Yeah, so the Jiffy knee replacement, we get a lot of questions about this. So the Jiffy knee replacement really is referring to a branded name for a surgical approach. I'm gonna just very briefly go back to one of the slides within the presentation here, just for the purposes of helping to illustrate this. So when we're talking about the surgical approaches here, so the surgical approach that we do for these or that I do for these partial knee replacements is the image on the right here. It's a subvastus approach. It is an incision that works under that quad muscle and avoids making any incisions into the tendon here. And that's really what that Jiffy knee is. So this type of approach is one that is very commonly utilized by surgeons. Many orthopedic surgeons have exposure to this in their training. Some prefer to use this. Some prefer to use that medial parapatellar approach. For many years, outcomes have shown very similar outcomes between them. But I think from the standpoint of trying to preserve that tendon and try to keep all that intact, there has been more of a recent movement towards trying to use that subvastus approach and preserve those soft tissues. So again, the answer that I have for patients when they ask me about this is the Jiffy knee is the brand name. The subvastus approach is the generic. They're the same treatment, the same type of surgical approach, and you can have very good outcomes with either one.
All right, thank you, Dr. Roedel. We have another question, this one from Paul. How much physical therapy is required for partial knee replacement?
So that is a very good question. That really comes down to the individual. And what I tell patients is that it comes down to where you're starting and what your goals are. So I can tell you on average that most of my patients do somewhere between 4 and 6 weeks of physical therapy after a partial knee replacement. Some patients may be starting from a spot where they're very active going into the surgery. They have very good muscle strength. They have very good range of motion. And so after the partial knee replacement, they come back and I see them at 2 weeks and they almost have all their full range of motion. They're walking without a limp. That individual probably needs very little physical therapy. They may be done after 2 or 3 weeks. Whereas someone who may have a little bit stiffer knee, has been more restricted in their activity, needs to work on building up their strength again after surgery, they may require a little bit more therapy. And then similarly, I've had some patients who have been very active, very much into hiking and other activities, and they have very specific goals about what they want to get back to after their partial knee replacement. And so they may utilize the expertise of a physical therapist to really make sure that they're advancing their recovery in a very efficient way. And so they may use more physical therapy to sort of get themselves to that next level of recovery. Hopefully that answers the question.
All right, great. Next question here from Stephanie. Do you need an MRI to determine whether a partial or total knee replacement is best?
Not always. So a weight-bearing X-ray is probably the most useful tool for determining if someone's a candidate for a partial versus total knee replacement. The weight-bearing X-ray is going to show areas where that cartilage is narrowed. So it really can help us to see, is there diffuse arthritis or is it focal to one area. The other piece that I think is really important is the physical exam. So if I see a patient who has bone-on-bone arthritis on the medial side of their knee, and they have some small bone spurs on the lateral side of the knee, but the cartilage space is still well preserved. And when I examine them, they have pain on the inside of the knee where it's narrowed, but no pain on the lateral side. Then even though there may be some early arthritic changes on that lateral side, they may still be a candidate for a partial knee replacement on that medial side. What I try to discuss with patients really are sort of the risks and benefits of either approach. Partial knee replacement and total knee replacement both can do very well. And what it really comes down to is for that individual, what, where's their pain? What are their goals? If someone tells me that they really just want to have, make sure that they have the knee taken care of and that they aren't going to have any risk of arthritis developing in the rest of the knee, then I'm not going to sit there and push that you have to have a partial knee replacement. A total knee replacement may do very well for them. But particularly in patients who are younger, who are active, who want to remain active as long as they can, a partial knee replacement remains a good option. Now, where MRI comes into that discussion is if someone, say they really look on their x-ray like they only have arthritis in one part of the knee, but they're telling me that they have some pain in the other part of the knee. What I want to evaluate with the MRI, maybe not so much their cartilage, but I may want to see what their meniscus looks like. If they have a meniscus tear on the other part of the other side of the knee, I may have more concern about are they going to develop more degenerative changes on that side over time. And so an MRI can be helpful to show us some of those soft tissues that the x-ray can't fully show us.
All right, great. Another question is, when is it determined if the press fit versus glue is determined? Is that through a bone density test?
So again, most of the partial knee replacements that that are going in the U.S. at this time are that cemented type of implant, and I would say for most surgeons, they're probably determining that preoperatively when they're talking to the patient and deciding on the type of implant that's being used. They're just speaking a little bit more broadly about press fit fixation, because that's also been growing with total knee replacements. Often we'll identify patients who may be good candidates for a press fit knee replacement, and we'll look at certain things like the patient's age, getting an idea on their x-ray of bone density, not necessarily with a bone density scan, but just looking at the general appearance of the bone on x-ray to see, does it look like we're seeing significant thinning that would be concerning for osteoporosis or osteopenia. And then looking at a few other health factors like metabolic factors that can predict bone health as well. And so in those cases, we may go into the surgery with sort of a plan A of doing a press fit knee replacement. But even then, during the surgery, we can often make the assessment what the bone looks like and feels like, and if we think a press fit implant is going to be supportive, or if it would be better treated with a cemented knee replacement.
Okay. Another question says, I had a partial knee replacement in September of 2024. Is weakness in the knee common even after this much time?
So there can be a few different reasons for weakness in the knee. What I'd say is that it's a little bit hard to sort of cast an umbrella to cover everything with that. I would say that the knee replacement or the knee should feel hopefully stronger than it did prior to the surgery when you're dealing with the arthritis. It may still not be quite as strong as it was before the arthritis had developed. Again, you've had a surgery at that point. You've had an incision that you've needed to heal, and there can be some scar tissue. But there can be other reasons why why a knee might not feel as strong as it did before. And so probably the best way to answer that for an individual would be to actually examine the knee and make sure that everything still looks like it's in good position and well fixed.
All right. We still have more questions coming. So,
All right, good.
um, I think you kind of referenced this before, but still a great question to ask here. Do you look at the total knee and determine if the remainder of the knee on the opposite side is showing wear or deterioration to determine that a partial is not worth it and should be a total knee replacement?
Absolutely. Yep. So we look at the knee comprehensively. So really the kind of the way that these sort of conversations go in my clinic is, someone comes in, they've got knee pain. Again, whether or not they're specifically asking for partial knee replacement, total knee replacement, or surgery at all, we're kind of looking at what sort of treatments have they tried. Are they ready for surgery? And then if we determine that they're at a point that surgery seems like it's the correct option, then we're looking at that knee as a whole and saying, okay, are we seeing some arthritis in other parts of the knee? Are you having pain in the other parts of the knee? And if I've got a patient that I am concerned that we're going to do a partial knee replacement and within a year or two, they're going to have issues that are going to require another surgery, then I wouldn't offer them a partial knee replacement, or I wouldn't advise a partial knee replacement. Really, I'm looking for patients that I think are going to have, a great long-term outcome, are going to have a single surgery that's going to last them hopefully decades without needing additional surgeries. So we definitely take that into consideration.
All right. We have a question here from Deb. 3 months after a partial knee replacement, I stepped wrong and ruptured my quad tendon. Do you see this often? And she wanted to note that she also does have rheumatoid arthritis.
Okay, so we don't see that often. I would not say that is a common complication after partial knee replacements or knee replacements in general. It is a possibility, but it's certainly possible that rheumatoid arthritis could play some role in that if there's some underlying degeneration within the tissues around the knee. I do think that by doing that, what we call that subvastus approach and leaving the quad tendon completely intact during the surgery, we may be able to reduce that risk. But I don't think it's completely taken out of the picture, especially if there's some level of inflammatory arthritis going on. There's still plenty of people who have falls or injuries where they, even without a partial knee replacement, they can rupture a tendon around the knee. So that possibility still exists, no matter really what we do. But I don't think it's very common.
Okay, thank you. A few more questions to go. This one is actually probably more for me to answer, actually. It says, will you be doing a webinar on total knee replacement? So Larry, you had asked that question, and our very first webinar was on robotic knee replacement surgery. Dr. Sullivan and Dr. Miller co-presented that. So if you want to find that recording, you can either go on our YouTube channel and find it there, or on osmsgb.com/webinars. If you scroll down to the bottom, there's a list of our past webinars that you can watch, and that one is there. So that doesn't mean we might not repeat it in the future, but we did do that topic already. So, all right, we have a couple more questions here, it looks like. And let me okay, what types of sports are allowed after partial knee replacement, and will I ever be able to run again?
All right, very good question, very common question that we get. So what I advise for patients is that low impact activities, things like walking, biking, swimming, elliptical, essentially unlimited low impact activity after knee replacement, partial or total. Really difficult for you to do any sort of damage to the knee replacement or its fixation with that type of activity. Now, when I have individuals who are looking to get back to a more active lifestyle, things like tennis, pickleball, um, running, or other impact type of sports, skiing, for example, um, those all come down to really individualized type conversations. What I tell patients is I've put the knee replacement in with the intention that it's going to last forever. So we're putting it in with very good cement technique to fix it to the bone. We're putting in the knee well balanced so it feels as similar or as close to the normal knee as it can, and hopefully will function as close to the normal knee as possible. But especially when we talk about that cement fixation to the bone, there's always some risk with repetitive high impact activity that things could loosen. Now, this has been something that's been investigated, and there's studies that have looked at, what are the rates of revision or the rates of loosening or failure. And it's hard to make conclusions to say that individuals who go back to those active lifestyles really truly see a higher rate of loosening or revision, but it remains, an area of concern. I don't think any surgeon. I think most surgeons would feel really terrible if they told someone, "Yep, go back to doing this activity," and then they found that it caused the joint replacement to fail. So, I do think a lot of surgeons will tend to be more conservative on this. Again, the conversation that I have with each patient is I tell them, if this is something that is really important to who you are, if running is, an intrinsic part of your personality, that you're like, if I couldn't run, I really wouldn't want to do this whole thing anyway, then I'd say absolutely run. This is your life, your quality of life is what we're trying to restore here. There's potentially some theoretical risk, and if something happens with the partial knee, then we'll help take care of it. But I would hate for you to be miserable saying, "Gosh, I had always wanted to go back and do that thing, and I was too nervous to do it, and feel regretful that way." So it's a decision. I want my patients to be informed about what the risks are, but I don't want them to be fearful.
Great. And then what looks like our last question, unless someone enters one by the time you answer this one, what is the incidence of HO? And if you can explain what HO is for everybody, what is the incidence of HO after a medial compartment arthroplasty?
Yeah. So HO is an abbreviation for heterotopic ossification. And just in very simple terms, that refers to a phenomenon that can happen after any sort of surgery in which soft tissues will have calcium deposits in them and actually become very bone-like. I will say that it's very uncommon after partial knee replacement. There are certain individuals who may have a genetic predisposition to this sort of condition where they will have a tendency to form more bone after surgical intervention. There are other risk factors that sometimes we can predict for individuals that might have that. But what I'll say is that the most common surgical risk factor for heterotopic ossification has to do with soft tissue trauma. And so I'll say that the areas that we traditionally see the highest rates of this condition would be for individuals who have had like a fracture in their pelvis. And it's a really invasive surgery to try to get exposure to be able to see in the area. There's lots of muscle stripping and injury to that muscle. And so there tends to be a higher rate of that ossific process happening afterwards. With partial knee replacement, by and large, we can be very, very kind and gentle to those soft tissues around the knee, preserve those soft tissues. And so the likelihood of developing HO is very low. I will say that one thing that we very commonly do now after partial knee replacements is treat patients with an NSAID medication, something like Celebrex or diclofenac or meloxicam. And these medications can help to prevent that or reduce the likelihood of that heterotopic ossification forming as well. So even though it's not very common, we do some things that help to keep that risk even lower.
All right. Well, that looks to be our last question. So, first of all, I wanted to thank you, Dr. Roedel, for your time today. I want to thank everybody who attended for their questions, their participating in today's session. We appreciate your engagement. We hope you found the discussion valuable. Just as a reminder, there will be a recording of this presentation made available on our website by early next week. And you can watch it there, whether it's on our website at osmsgb.com/webinars, or you can find it on our YouTube channel. If you have any further questions or would like to schedule an appointment with Dr. Roedel or any of his partners, you can do so by calling 920-430-8113, or you can actually schedule online as well at osmsgb.com. Thank you so much, everybody, and hope you have a great night. Take care.
Thank you.